Okay, good morning. Today's topic, acute abdomen. It's a very broad topic, brought to you by Ada Gastash. She's been here with us for 2 years. She comes from Berlin, and I very much like the way you prepared this presentation, so I hope you enjoy. Thank you.
Thank you, Dr. de Rougemont, for your kind introduction and also for your help. Good morning, everyone. I would like to welcome you to our today's morning lecture, which will be about acute abdomen. And I would like to start with a clinical scenario right away. So imagine yourself in the emergency department and you're seeing a 65-year-old patient presenting himself with fever, diarrhea, nausea, and severe crampy abdominal pain. On your physical examination, the abdomen is tender to palpation. The patient shows diffuse guarding, but no rebound. Maybe you just take some seconds to think about this. So I assume that your first impression is, okay, this patient suffers from an acute abdomen, which is correct. But what is an acute abdomen really? Can we define it? Of course, there is a definition of an acute abdomen. It's defined as a sudden onset of a severe abdominal pain regardless of the cause. Well, that doesn't really help a lot, right? So as we know, there is no specific definition of an acute abdomen, as it is not a diagnosis. It's rather a term used clinically descriptive. To understand the abdominal pain, I would like to just quickly show the different layers of the peritoneum, which I'm sure that you're familiar to. So in this picture, you see the blue outline suggesting the layers of the peritoneum, for once the visceral and the parietal peritoneum. The visceral pain is caused by autonomic fibers mediated by distension and ischemia. It is rather a vague pain. It's dull, it's nauseating, and poorly localized, whereas the parietal pain is a response of somatic nerves to irritation from infectious or inflammatory processes, and this information is led to the spinal cord, and that's why it's very sharp and well localized. Depending on the location of the pain, with regard to the 4 abdominal quadrants, there are many differential diagnoses to be taken into consideration. So let's start with the right lower quadrant. What do we think if the pain is located here? It's a simple question. Maybe also our students can answer if they would like to. What do we suspect if the pain is in the lower right abdomen?
Maybe acute appendicitis.
Thank you very much. This is correct. If we think of female patients, of course, we also have to think about an ovarian torsion. For example, if the patient has an ovarian cyst and it ruptures and then causing a torsion of the ovaries. Also adnexitis or ectopic pregnancies, as well as incarcerated inguinal hernias. Next question, if the pain is located on the right upper quadrant, what do we expect?
Maybe acute cholecystitis.
It's right, thank you. Exactly. It can be an acute cholecystitis. It can also be a cholangitis. Do you know the 2 other symptoms that are caused by a cholangitis? I heard it already. It's also fever and jaundice. And this triad of these 3 symptoms is called the Charcot triad, as you know. Hepatitis, of course, is also a possible cause for right upper quadrant pain. If the pain is located rather on the left-handed side, think of spleen injuries, especially if the patient has had a trauma. If the pain is located on the left lower quadrant, it can be the same causes like on the right-handed side, of course, but what do we have here as well as a differential diagnosis? It's the diverticulitis. Diverticulitis, a volvulus, or a perforation. If the pain is located on the upper abdomen in general, think of a pancreatitis or of peptic ulcers. Whereas the acute mesenteric ischemia, small bowel obstructions, or the aortic aneurysms usually present themselves with pain in the midline. So if you see this slide, you see that there are multiple causes that need to be considered, and this listing is not even complete. So there's even way more. For surgeons, of course, it's important to know, is the acute abdomen a surgical abdomen, meaning an acute abdomen that requires surgical treatment? Often these two terms are used as synonyms, but as you know, not all acute abdomens are treated appropriately with surgical intervention. So in order to find that out, we need a complete and thorough history of the patient. After knowing where the pain is, you ask for the quality of the pain. So is the pain rather colicky, or like in a mesenteric ischemia, for example, or cholecystitis? Or is it a severe tearing pain, like in a ruptured aortic aneurysm or dissecting aneurysm? Or is the pain rather dull, like in an appendicitis or diverticulitis? A good way actually for checking recurrent problems is asking for it. Ask if the patient has had the symptoms already in his or her past. And this is actually giving you a hint of potential ulcers or gallstones, or also if the patient has had an episode of diverticulitis in his or her past. Especially dangerous is the acute onset of symptoms. So this is actually suggesting the possibility of a perforation or a rupture. And of course, the severity of the pain. If the pain is completely out of proportion to your physical findings, you should think of an acute mesenteric ischemia, but we will come to that in a minute. And last but not least, it can help if you ask if the pain travels to another part of the body, for example, to the back, like it can occur in a pancreatitis or a dissection or sometimes peptic ulcers. So now, you did a thorough anamnesis of the abdominal pain, and now you can move on to your physical examination. And this should start with the general glimpse at the patient. Is your patient in severe pain? Is your patient anxious? Is he or she pale or diaphoretic, meaning sweating? And here you have to watch out, especially in elderly patients, as they often do not show any signs of severe abdominal pain. They rather present themselves already in a shock situation. So also check for the vital signs and also the state of consciousness. And now you start with your focused abdominal examination. Take a look, inspect the abdomen. Is it distended? Do you see any scars? Because sometimes we ask for previous abdominal surgeries. The patient says no. And when you say, okay, but I see a scar here, they say, well, yeah, 25 years ago, I had an appendectomy or colon resection. The next thing you do, you check for the bowel sounds to see if there are any. And finally, it's time to do the palpation. Here, it's important to check any guarding, any rigidity of the abdomen. Does the patient show any signs of rebound, or can you palpate even any masses? As part of the diagnostic workup, blood results and blood testings are always done, but actually are of little value due to poor specificity. But of course, it's important for female patients to rule out pregnancies if the female patient is in a childbearing aged state. An EFAS is done if hemorrhage is suspected, or ultrasound in general if you think that the patient might suffer from an appendicitis, cholecystitis, or also ectopic pregnancy. An ECG is mandatory if the patient has upper abdominal pain. This is really mandatory. You need to do that to rule out a myocardial infarction. At university, I know that we always learn that an X-ray of the abdomen can be done, but actually in practice, the use of an X-ray is an extremely low yield practice, as it is not much sensitive, nor is it specific. So the modality of choice is the evaluation of an undifferentiated abdomen via a CT scan, a contrasted CT scan, as it is diagnostic in 95%. So now let's go through some causes of the acute abdomen, starting with the acute mesenteric ischemia. The AMI is defined as a sudden onset or sudden interruption of the intestinal blood flow, leading to ischemia and subsequently to infarction, and therefore it has a very high rate of mortality. The intestines are mainly supplied by two major arteries, which is ones, the SMA, the superior mesenteric artery, supplying the intestine from the distal duodenum to the splenic flexure, and the IMA, the inferior mesenteric artery, taking over from the splenic flexure down to the upper part of the rectum. Also, the celiac artery actually supplies the intestines with collaterals. In the colon, you find so-called watershed zones, watershed areas, including the splenic flexure, which is called the Griffiths point, and also the rectosigmoid junction, which is called the Sudex point. And this means that these are regions that are supplied by two major arteries, and the splenic flexure is supplied by the SMA and the IMA. And I find it interesting that in times of blockage of one of these two arteries, these areas are spared out from ischemia because of their dual supply. On the other hand, however, if you have, or during times of a hypoperfusion, for example, cardiac shock, these areas are most likely to suffer from ischemia as they're supplied by the most distal branches of these arteries. Clinically, the patients with an AMI present themselves with an acute onset of abdominal pain. They feel nauseous, they suffer from vomiting and diarrhea. And as I said in the beginning, if you see that the abdominal pain, that the severe abdominal pain is out of proportion to your clinical examination, you must assume an AMI until it's proven otherwise. Because this patient might be or will be in a hyperactive phase where you find this discrepancy between the pain and the clinical findings. It's within the first 6 hours, followed by the paralytic phase where the abdomen becomes more distended. You find reduced bowel sounds. In German, it's called the so-called Totenstille. And this ends in the septic phase with volume leakage and a threatening state of shock. There are different risk factors of a mesenteric ischemia. On the one hand, you have the occlusive mesenteric ischemia that count for 60% of all total cases. They can be embolic. For example, if the patient suffers from a valvular heart disease or atrial fibrillation, or it can be thrombotic due to generalized atherosclerosis. Then you have the NOMIs, the non-occlusive mesenteric ischemias, counting for 30% of the cases. And this is due to a low flow state, for example, cardiac failure, a severe shock situation. And also the mesenteric venous thrombosis, which can be due to inflammatory conditions. Generally speaking, the AMI is a rare condition for acute surgical admissions, but in a tertiary center with a cardiac department, cardiac surgery department like us, the incidence of the NOMIs, the non-occlusive mesenteric ischemias, is of course way higher because we have more patients suffering from heart failure and also leading to a much higher incidence in total. And why I present you this topic is because it has a really high mortality. You see here almost 75% of the occlusive mesenteric ischemias patients will die. The modality of choice here is, of course, the CT scan with a triple phase, which means pre-contrast, arterial, and a venous phase. Maybe someone would like to know what we see here? Okay, so I take over. You see a sudden interruption of the SMA, right? Exactly where the arrow shows it. The correct therapy, first of all, is of course a resuscitation to enhance the perfusion. You administer broad spectrum antibiotics because the perforation cannot be excluded. And you try to go for a minimal invasive revascularization, if it's possible, by the interventional radiologists. And after this revascularization, you should definitely offer an on-demand laparoscopy to check on the bowel, as I said, after the revascularization to prevent any perforation. However, if the patient presents peritoneal signs, you rather go directly to the OR, try to do the revascularization surgically, although it's very difficult and often not feasible. And then you check for the bowel itself, see if it is viable. So do you see any visible, or can you palpate the pulsations? Is the color normal? Do you see any peristalsis? And if not, you proceed with a resection of this particular part. The next clinical picture I would like to talk about is the intestinal obstruction. It is a significant mechanical impairment or a complete arrest of the passage. And why it is so dangerous is because perforation can occur in little as 6 hours due to the ischemia, so we do not have a lot of time. You can find the obstruction in the colon because, for example, of tumors, can be a volvulus. It can also be a diverticulitis causing this obstruction. And if you remember, some months ago, I held a presentation on diverticulitis where I showed you this picture. So next to abscesses or perforation that can take place, you see here that also a stenosis can be a complication of a diverticulitis due to a chronic recurrent diverticulitis. And that's why it's actually important to ask the patient if he has had or she has had any episodes in his or her past showing that she or he maybe had a diverticulitis already. You can also find an obstruction in the duodenum due to a tumor of the duodenum itself or of the head of the pancreas causing a compression due to the topography, causing a compression of the duodenum. And the reason for jejunal obstructions often are incarcerated hernias, can also be due to tumors or adhesions due to prior surgery. Most patients with small bowel obstructions will present acutely with abdominal pain, nausea, vomiting, obstipation, or even lack of flatus. And patients with a volvulus usually speak of a very abrupt onset of symptoms. As mentioned already, the value of a plain X-ray is limited. In a high-grade obstruction, you can see a triad of multiple air fluid levels. You can see a distension of the small bowel loops, and you can also see the absence of gas in the colon. And these three symptoms or findings are pathognomonic for a small bowel obstruction. But overall, the specificity and the sensitivity is really low here for the plain X-rays. So, and it also does not detect any early signs of peritonitis either. So CT scans is, again, here the modality of choice, as it is a very good diagnostic tool to detect it in an early stage. Here you can see some examples. I don't know whether you can see it on the big screen, but in the middle picture, you can already see that the bowel is distended without any diagnostics. Can you tell me what sign you see here?
The coffee bean sign.
Thank you, that's correct. And the coffee bean sign is a sign for a volvulus. That's completely correct. On the left-handed side, you actually see a cecal volvulus that already turned and flipped to the left upper quadrant, and on the right-handed side, you see a sigmoid volvulus. The correct treatment of small bowel obstructions is derived from the Bologna guidelines. First off, you start with insertion of a nasogastric tube for decompression. You do a resuscitation, and also antibiotics should be administered if a perforation is suspected. If you have signs of a closed loop bowel ischemia and free fluid, you definitely go do emergency surgery, but generally speaking, you can say that around 85% of the partial small bowel obstructions can be treated with no surgery, whereas the same percentage, so 85% of the complete small bowel obstructions need surgery. And what I found interesting is that when you have a cecal volvulus, you rather go for a resection anyway. And if you have a sigmoid volvulus, you can try to do an endoscopic detorsion. And if this is not successful, you go for surgery. It's also said that a sigmoidopexy can be done, but generally speaking, it's not recommended as the recurrence rate is higher. And the last topic I would like to present you is the acute perforation, as it can result from an AMI or an obstruction. It is so dangerous because you have really little time from the onset of the symptoms until the first signs of shock, causing a high mortality rate. It can occur in the stomach, or in the duodenum in case of a peptic ulcer disease, or by obstruction if it's in the intestines. It can also or take place in the colon if you have any obstructions or diverticulitis or IBDs. Patients with an acute perforation show directly peritoneal signs: nausea, vomiting. The bowel sounds are rather absent. And here also in an X-ray, you can see free air under the diaphragm, but for that, you actually have to lay the patient for at least 10 to 15 minutes. And these minutes is time that you do not have or that you do not want to waste. So again, we go for the CT scan, if possible with IV contrast, to have it less difficult for the radiologists. But it's actually also possible to see free air pre-contrast or with no contrast. And if the site of the perforation can be detected by the radiologist, of course, it's easier for the surgeon to go to the surgery or to proceed the surgery. An immediate insertion of nasogastric tube is also indicated here, resuscitation and antibiotics because of the perforation. And bringing the patient to the emergency surgery is due to the high mortality rate. So to close my talk and putting everything into a nutshell, and it was a lot of information, I know. I would like you to remember that it's the most important thing to look out for the life-threatening causes first. I know it sounds very easy, but it's really not, as there are a lot of differential diagnoses that need to be taken into consideration. Then you have to decide whether the acute abdomen is an acute abdomen, so can we help with surgery? And in order to find that out, the most efficient way is to use a CT scan, a contrasted CT scan. And there are different ways of contrast. So I'm very happy that Dr. Höttger is here from the radiology to discuss with us the indications for the different contrasts. And that was it from my side. I thank you very much for your attention.
Adak, thank you very much. It was a very semantic talk, and I think it's important to repeat the basic stuff too. So are there any questions from staff, from the residents?
I think there's a number of questions that we need to look at. First of all, thank you very much. Very nice, comprehensive overview of this topic. First of all, I have a question to the two of you who have prepared this talk, but also our radiologist. So what is the value of the conventional X-ray? You've been fairly critical of conventional X-ray. Is there a specific role, or should we completely forget the conventional X-ray, go straight to CT scans?
Well, I can answer it from a clinical point of view. I think from my side, it's useless if you have a CT. But I'd be happy to have the answer from the radiologist.
There are some very few indications when you want to check for the position of tubes, things like that, or you want to check if your feeding tube is correct, things like that. But for emergency, this really, in my opinion, has no place anymore. You go for CT if you can with IV contrast, no oral contrast, don't waste time. Just go for a CT with IV. If not possible, then do a native scan. This is very high sensitivity and specificity for free air. That's basically what you're looking for.
Okay, thank you. Very clear statement. So no conventional X-rays in the emergency room, but in the emergency room, I think that must be stated very clearly. That is a completely different topic when we have patients on the floor, where we use conventional X-rays for all kind of indications, small bowel, contrast follow-throughs, just for example. So I think you have to differentiate that. But then the emergency department's a waste of time. Okay, it is a waste of time. The other thing I would just briefly like to mention, because I think your talk went straight into some of the more elaborate problems. But when it comes to bowel obstruction, I may want to ask the residents, what is more frequent? Is it small bowel obstruction or large bowel obstruction? Which one is more frequent?
Small bowel obstruction.
By a factor of, would you say 50-50, 60-40?
70-30.
Yeah, it's probably in that area, like 80% small bowel, 20% large bowel obstruction. And my next question would be, if you think of the etiologies for obstruction, which is the most frequent in small bowel obstruction, which is the most frequent in large bowel obstruction? And I think that's an important point to make.
In the large bowel, probably tumors. And in the small bowel, adhesions from
Thank you, and I
previous
already like
surgery?
to stop you there because that's very well put. Large bowel obstruction, until proven otherwise, is a tumor. Small bowel obstruction can be all kind of different things, but it's mostly adhesions that we see. And so therefore, how would you want to work up a large bowel obstruction? What kind of testing do you do?
For large bowel scans and then colonoscopy, if possible, if you can pass through, and then after that, surgery.
Are you able to do the patient that you have stated initially was a 65-year-old gentleman who, let's say, arrives at 10 p.m. and he's having diffuse abdominal pain, and you do a CT scan. You're not wasting your time with conventional. You do a CT scan, and you find a mass in the sigmoid area. Would you prepare this patient for colonoscopy?
Not in this setting.
Well, I think it's colonoscopy is rather dangerous. You're putting air into your colon, and which will lead to the dilatation of the colon behind the stenosis, and eventually lead to rupture of the cecum. So I would rather go for surgery straight and remove the problem.
You may be able in some patients to do a flexible sigmoidoscopy and just get at the lowermost part of the problem, but it's actually dangerous to do a full colonoscopy in such a patient because A, you will not be able to prepare the patient. If he's in large bowel obstruction, you will not be able to do a bowel prep on him. And if you force your colonoscopy, still at this point, you just risk perforation of the proximal colon. So you have to be careful about that. And I would also assume that if your suspicion for malignancy is high enough, you have an indication already for surgery.
Yeah, thank you for the great talk. I have another question to maybe also to the radiologist. When I was trained years ago, we also performed emergency CT scans, but there was basically no CT scans without rectal contrast. And I know for radiologists this is not very pleasant, but what gives the rectal contrast as additional information? And do we have to insist as visceral surgeons when we ask you for the CT scan?
Contrast and oral contrast in general is probably one of the most debated things in radiology. Oral contrast in general stems from a time where we had these old CT scans which produced slices about a centimeter or more, and it was really difficult with the spatial resolution that you had to follow the bowel through the CT, and that's why we originally gave those contrasts, and this has become kind of a tradition in radiology. Nowadays, with those fancy scanners we have, we don't need that, and 90% of the abdominal CT scans that we do without contrast. Particularly, it has proven to be not useful appendicitis, diverticulitis, stagings, with some few exceptions regarding peritoneal carcinomatosis, where you can see those tumors much better. It has some value, for example, in bariatric surgery, after bariatric surgery, if you want to check for anastomosis. But for the vast majority, we don't do oral contrast anymore because the main argument is that you prolong time to diagnosis. You usually don't know what you're getting in your CT scan, but it takes 1.5 hours to really make the patient drink the contrast. So we usually don't do that. For the rectal, there is unfortunately a lot of evidence to not do it. It does not give you any significant advantage anymore. So you could do diverticulitis, and there are studies that even do native scans, low dose, to diagnose appendicitis, diverticulitis, and they report rates that are nearly as high as a normal scan. What we do, usually we still do it because it makes just nicer images, but it's really not necessary. What you're really looking for is the changes in the surrounding fat, and that for that you don't really need contrast.
Well, you said you should not do oral contrast, right? So, but this is what we like to do because it's not only imaging; it's also that we have some effects from the gastrografin. So is this really delaying? Somebody has a gastric tube and drinks a little bit. We don't go for, the full. If the patient did not drink,
there is some evidence in if you have small bowel obstruction. It makes it sometimes a little bit easier. It's really not necessary. We can 99% of the time we can do this without oral contrast, the same accuracy that we have. sometimes it's nice to have this gradient throughout the bowel to be able to differentiate those different parts of bowel. Giving oral contrast with those propulsive effects sometimes is very valuable. There's just one exception I want to make, particularly for the residents. Don't do this if you're suspecting a bleeding, enteral bleeding. That's very important, because we always get those scans where we're asked for this, and then from intensive care or whatnot, and then the whole colon, the whole bowel is full of gastrografin. We're saying, well, we don't know. That's the only exception to that rule. I think if you have the time, why not? But if you don't have the time, and this is something that where every minute counts, that's what you're expecting, then don't waste time on oral contrast. It's really not that helpful.
So we really have to differentiate if we're having an acute abdomen or if we are looking for a specific cause, because we do not only like oral contrast. Personally, I very much like rectal contrast. And I'll give you an example, which was a patient last week who we sent for a CT scan with a pararectal abscess following low anterior resection. The CT was done without contrast, and that really, we're really missing out on half of the information that we are getting otherwise by doing a contrast-mediated CT scan where rectal, so to speak, contrast was given. So I think, again, probably the elective setting versus the acute abdomen setting may just make a big difference.
In particular, if you're looking for anastomosis leakage or something, in particular rectal, esophageal, then we should always give rectal contrast, or actually we give 2 times contrast. We first let the patient drink the contrast, and then when he's on the CT table, we do something that's called Schluckauftisch. For whatever reason, the patient drinks on the CT table, and then we do directly do the scan, so that we have best contrast in the esophagus. That's the normal procedure.
So not everything is 100%.
No, not even in radiology.
Okay. Thank you very much. We're advanced in time. Excellent presentation. Thank you very much. Very well prepared. Thank you. Have a good day.